Oh, kenapa tak keluar?
Apa ni? Apa ni?
Keluar.
Good evening, everyone. Today I'm going to present a complicated case of perforated sigmoid diverticulitis, which we have been managing for the past 2 years. So this is a 52-year-old Chinese male with underlying SLE with rapidly progressive glomerular nephritis and long-term penicillin, adrenal insufficiency secondary to exogenous steroid, epilepsy, SVT, post-radio frequency ablation. So he initially presented to us in February 2022 with acute rheumatic with lower abdominal pain over preceding 3 weeks, associated with previous diarrhea and significant weight loss. CT scan was done, which showed perforated sigmoid diverticulitis in G4. So he underwent an emergency laparotomy and Hartmann's procedure. He was a difficult Hartmann with large progression at the distal sigmoid with adjacent necrosis segment, forming a rectal sigmoid mass adhered to sacral promontory, IMA, IMB, and left urethra. Left urethra was preserved but skeletonized in certain areas. HPD was perforated diverticulitis. So he had a stolen recovery complicated with bacteremia, ileus, and surgical site infection. He was discharged for 1 month post-operation. 2 weeks later, he presented with poor rectal and abdominal discomfort, and CT scan showed rectal stapling with abscesses and bilateral osteotic neuropathy. So this is the CT scan which I'm going to have a quick run through. As you can see from here, there are bilateral hydronephrosis and bilateral hydroureter, and there is a collection at the left iliac fossa here. And going down into the pelvis, there is another collection in the presacral region around the rectus stomach. So at that point, we were considering whether we should bring patient in back to operation theatre or choose for non-operative management, such as drainage. So we were patients immunocompromised, and he was not keen for operative management at that point. We decided for non-operative management with antibiotic, and he underwent severe endoscopic drainage, followed by the CT reassessment, which showed persistent rectal stomach leak with smaller presacral collection, and the collection at the left iliac fossa has resolved. There is also a persistent left hydronephrosis and hydroureter. So in view of the collection and his sepsis, so he underwent left RPT, laparotomy, heliciolysis, and draining of pelvic collection. So during the operation, there is an extravasation of contrast and pelvic urine, which means there's suspicious of left mid-ureter injury, and there's dense adhesion of small bowel to pelvis and left iliac fossa, and pus around 200 cc in pelvis. So post-op, he underwent left nephrostomy, and he had prolonged stay again the work for drainage of his pelvic collection and laparotomy surgical site infection. So 2 months later during the follow-up, CT scan shows slightly small presacral collection, and he was well at that point, so we put him out for the sigmoidoscope, which showed a persistent rectal stump leak with fiber tissue. We attempted endoscopy clipping. Post-clipping, the defect appears to be closed, and he also had a APG, fluoroscopy, and CTU, which showed left ureteral rectal stump fistula, suspicious ureteral colon fistula, and small presacral collection. He is otherwise well with no complaints, and he was planned for conservative management down along the line, he presented with left abdominal wall cellulitis around the drainage site, which subsequently drained urine, and he was admitted to us in February 2023, which infected drain site with urine discharge. CT scan showed evidence of rectal ureteral cutaneous fistula. So this is the CT scan. Going to the area of interest, you can see this is the left kidney and this is the left ureter, and there's an obvious hydro ureter. And following down the contrast, so there's still contrast at this region, and following down through it, there's a abrupt tapering around this region at the mid-ureter. And now I'll bring your attention to another area of interest, which is at this drainage site, at the anterior abdominal wall. As you can see from here, there's contrast flow flowing down around the abrupt tapering of the ureter, and you can see from here, there's a hypotense tract tracking down into the pelvis, into the pre-sacral region around the rectus stump. So the CT scan showed evidence of rectal ureteral cutaneous fistula, and he was treated conservatively in the ward with antibiotic and discussed. So the issue we identified for him is a poor healing capacity, with fistula and rectal stump leak not healing despite maximum decompression and diversion after 1 year, with symptomatic rectal ureteral cutaneous fistula, urine leak despite left nephrostomy. So what would be the option for our patient at this point? We had an MDD discussion with him on further management, and 3 options were given: conservative, no surgical intervention, ligation of ureter, then lifelong nephrostomy, or left nephrectomy. So patient opted for left nephrectomy, and he was electively admitted in April last year for left nephrectomy, refractory of ankylostomy, excision ureteral cutaneous fistula, small bowel ileolysis, ilioendogenous small bowel anastomosis, and closure of distal stump. So he was discharged well on day 10 post-operation. Unfortunately, in 2 weeks' time, he presented to us with intra-abdominal sepsis. CT scan showed there is pre-sacral collection, rectal cutaneous fistula with initial obstruction of small bowel. Just quickly run through the CT scan. As you can see from here, there's small bowel dilatation, and there's right hydronephrosis with hydroureter. And going down to the pelvis, it's a rectus stump, and there's contrast leak from the rectus stump. It's a contrast leak. So he had another major operation, right hrpb and uterus stenting, sigmoidoscope, abdomen, drainage and collection and packing. And it was another difficult operation with dense adhesion, and there is iatrogenic perforation at the urinary bladder. He was in DIBC. Packing was done in view of unwanted content bleeding due to fiber venous pressures. So the packing was removed 2 days later. So here another prolonged stay for sepsis, ileus, and tracheotomy surgical site infection, and repeated CT cystogram in 6 weeks showed there is no contrast leak from urinary bladder. However, there was urine leak. Clinically, there was urine leak from his abdominal drain with high urine creatinine, which is equivalent to urine creatinine. Hence, he was discharged home with CBD, abdominal drain, and antibiotics coverage. So during his outpatient follow-up 6 weeks later, with a CT cystogram reassessment, there's evidence of rectal vesicle and rectal cutaneous fistula. So I'm going to show you this sagittal view of the CT plain CT cystogram with only rectal contrast given. As you can see from here, there is a contrast flow in the urinary bladder, which suggestive of rectal vesicle fistula. He was well with no active complaint at that point, so we put up for sigmoidoscope, noted there is a rectal sound defect which we attempted to seal with histoecho glue, and in another 6 week time we assessed with another sigmoidoscope, noted there's a new stapling at another site communicating into pelvic cavity. Again, we